Okay, everyone. Good morning. For those of you who do not know me, my name is Brenda Carter, and I'm the state representative from the great state of Michigan and vice chair of this committee. The chair of this committee, Senator Paul Utke, unfortunately couldn't be with us this week, so I'll be chairing this meeting. I'm going to begin by asking for a motion to waive the quorum. Now I ask for support. Who moved and supported? It's been moved and supported. All in favor, say aye.
Aye.
Those opposed, same right. Motion's carried. Now I ask for a motion to adopt the March 4th, 2022 meeting minutes. Can I have a motion, please? Can I have a support?
Second.
Okay, all in favor, please say aye.
Aye.
Those opposed, same right. The motion is carried. We'll start today with a continued discussion on the 340B drug pricing program. This topic was previously being discussed in the Health Committee, but at the spring meeting in March, it was announced that it would be transferred to this committee. Since the 340B drug pricing program is a federal program, it made sense to transfer the topic to this committee. Today is really about information gathering and further education on the program, and after today, we will evaluate what, if any, next steps will be involved with this topic. Let's start with talking with Assemblywoman Pam Hunter.
Thank you, Chair. I appreciate you letting me make a few brief remarks since we did move this topic from the Health Committee our last session. It's been a very important conversation in New York. We've had long-standing discussions about 340B and the savings. We want to make sure that any savings continue to go towards those programs and services, especially federally qualified health centers. So I'm definitely interested in hearing how we can have a robust discussion on this, especially at the federal level, and wanting to make sure those who are taking the savings, who don't need it, are putting other programs in peril. So with that, Chair, I will let you proceed.
Thank you, Assemblywoman. And now we'll begin our panel discussion. On our panel today is Dr. Wayne Weingarten, Senior Fellow, Business and Economics, Pacific Research Institute, and Miranda Mater, Senior Vice President, State Affairs and Policy, America's Health Insurance Plans. So please go ahead, Wayne.
Thank you so much, and I appreciate the opportunity to be here. And I think what the Assemblywoman said in terms of ensuring the program exists for those institutions, those hospitals, those centers that it's made for, I think that is the most compelling reason why we need to reform the program. And I can get that. I have some slides. I don't know how to make this work. I apologize. There we go. I can't take credit for that, but thank you. So let me start with a very quick elevator pitch in terms of why 340B needs reform, and then kind of spend the rest of my 10 minutes here just trying to back this up to convince you that it's an important program. What we're trying to do is very important, but we're doing it very poorly, and that puts the entire program in jeopardy because it right now is completely unsustainable. The reason it's unsustainable is because when you look at the growth, whether you measure the growth of dollar value of drugs going through, number of hospitals or entities, covered entities as referred to, that participate in the program, whether you're talking about the number of contract pharmacies, that growth has been out of control. Now, if it was actually achieving its purpose, that would make sense, but it's not. So we have out-of-control growth combined with a program that's not actually doing what it's supposed to do, and then it has ancillary impacts, which includes your incentivizing more expensive medicines to be used, you're actually raising costs for other users of drugs, and you're actually incentivizing a consolidation in the medical practices, which when you do it for 340B is actually inefficient, raises costs, and hurts quality of care. I think you're familiar with 340B, but let me just go through it very quickly, just in case some of us aren't. The purpose of 340B is to help ensure patients have the needed medicines by supporting hospitals or clinics that are serving what they call disproportionate share, but basically lower income people, particularly people without insurance. If you look at the history of it, it's actually interesting because it's a little bit of the old woman who swallowed the fly, where it was once you had pharmaceutical companies provided low-cost medicines, sometimes for free, to these same types of hospitals or entities. But then when Medicaid came along and they had the reform in 1990, and you had best price. Well, best price, if I'm giving the medicine away for free, that's your best price. That's something you can do for a small share of hospitals. You can't do that for the entire Medicaid program. So you actually, from one reform, trying to do something over here, you squeeze the balloon, you cause the problem over here, so now we squeeze the balloon again and we create a 340B. And the idea for 340B is we're going to allow these covered entities to purchase the drug at a lower price. That lower price, they get reimbursed at the higher rate, which is in subsidy, which they're then supposed to use to expand care. Talking about discounts, it can be 50% more, and actually on average they're right now significantly more. A very simple kind of example of how this works, and it's simple because I'm not including margins, markups, all these other kind of fun things, or when you talk about prices in the drug industry, that's, we can have a whole conversation about that. But if we assume a drug with a price of $1,000, if you have a 340B discount of 50%, then that hospital, when they're purchasing the drug, assume an infusion drug for cancer, you're actually only going to pay $500. Even though you paid $500, the insurer or Medicare or whoever that is going to reimburse at the full value. Actually, Medicare would be ASP plus 6%, but we'll just call it $1,000. That means what we've now done is given that hospital $500. Now, what's really important to remember, though, is that that $500 came from the pharmaceutical manufacturer, which when you're talking about the program when it's contained, it's part of kind of charitable operations. It's doable. When the program grows beyond something that they can afford, you end up with restrictions, which is what we're actually seeing in the program now. Entities that deserve these types of discounts are actually finding it very hard to maintain them. Starting with the growth very quickly, and this chart came from Drug Channels, which if you're not familiar is a fantastic source in all things drugs. And there's two bars in this, which is why this one's interesting. The light blue bar is what we guesstimate, what they guesstimate the price of the drugs are, the cost of the drugs at the 340B discounted price. In this case, it's purple bars. That's at the list price, or what they call wholesale acquisition cost. And what you see is, if you focus on the blue bar, that's a 27% average annual growth a year. So you have the revenues in this program are growing at kind of what they're paying, 27% a year. Now, to see how excessive that is, manufacturer revenues are going 5% a year. So you see a huge increase in the dollar value going through this program. And you can see a large part of that, that's kind of at the end at 2020 there, is through contract pharmacies, which we'll come back to. That's one of the big problems in terms of why this program is having more fraud issues and is growing out of control. If you look at, and this is IQVIA, they take the kind of that WAC price data, so that purple bar, all the way to 2021, you can see it's now going to $94 billion, or 14% of all drug spending valued at this price. That's just an incredible growth. It's become the second largest kind of program, discount in the system. So it's supposed to be something that's kind of tailored to specific hospitals serving low income. Now we're at 14% and the largest or second largest discount program. And why that's happened, and to me what really amazes me about this chart, and this is from IQVIA again, the light blue bar is what they call covered entities, hospitals, things of that nature. And it looks like it's not growing. But that grew 50% between 2010 and 2020. Now, why is 2010 important? Because that's when we had some changes that, one, allowed entities to have as many contract pharmacies as they want. Interesting about contract pharmacies, they were put in there because some of these entities, the ones that are deserving of the discount, they didn't have pharmacies internally. So you have a hospital, a huge hospital system, have their own pharmacy. Many of these entities didn't, so you allowed to have one contract pharmacy. In 2010, it was decided you could have multiple, as many as you want. Some institutions now have 150 contract pharmacies. And so you can see in that green bar how much that's grown. right? It's so excessive that you can't even see the growth in the number of covered, number of entities, which is huge in and of itself. And then the bar in between, which is also very important, is entity sites, because you have that incentive to consolidate, to bring independent practices into your hospital system. And this is evidence that that incentive is actually working, that we're actually buying up practices and bringing them into the hospital system. And basically the reason is for the 340B discount. So with the relaxation in Medicaid and with the relaxation on the restriction of contract pharmacies all around 2010, we've seen a huge growth in this program. In terms of contract pharmacies, why that's very important, and the type is a little small, I apologize for that. If we're talking about almost 30,000 contract pharmacies, 70% of those are Walgreens, are CVS. They're actually getting about 25% of the revenues from 340B, because when you fill a prescription in your contract pharmacy, you get a higher rate than you would on a normal prescription. 70% are going through huge big name companies. So here's one kind of problem with the program. Contract pharmacies have exploded. They're getting a big chunk of the money, and they're not the intended institutes we're trying to support. So we have this just offshoot of all of the revenues going to these contract pharmacies. That's a huge problem. If we're looking at the hospitals themselves, and this is now citing some of the research I've done, where we looked at a sample of hospitals. In this case, this is looking at a sample of 340B hospitals, and we went through the 990s to see if we can get a sense of how much their revenues are growing compared to the average hospital. And you can see average annual revenue growth is significantly higher in a 340B, however you measure that, average, medians, mean, doesn't matter. We have a higher revenue growth compared to your average hospital. Not only do we have higher revenue growth, our profit growth compared to kind of some basic benchmarks is excessive. So what we're seeing is growth in revenues in the hospital systems, growth in profits in the hospital systems. But when you look at also the profitability, and this is actually, we're able to not just do a sample, we can look at all 340B hospitals. This is for 2017. They are actually more profitable, right? Their excess revenues, in case you're a nonprofit institution, relative to revenues at 340B hospitals are significantly higher, 25% higher. So we have incredibly profitable institutions with strong growth in revenues, strong growth in profits. Big problem, they're not spending more on charity care. Right? If you look at how much they're spending on charity care, it's about an average of 1.66% compared to a bit over 2% for your average hospital. So we have subsidization of the program. It's expanded to the point where it's not achieving its purpose. That purpose is important, but we need to reform 340B to bring it back to that issue. And why is that doing that? I'm checking the time real quickly. I think I'm running out of time, so I'll go through this very quickly. Part of the problem is when you're incentivizing high-cost medicines. So and that just gets to how the markup works. 50% of a higher number is a larger amount. What we actually see, and this is from a GAO study, that they are actually prescribing more drugs and they're prescribing more expensive drugs. So 340B is incenting all these hospitals that are growing to spend a lot more, or to use higher cost drugs. They also, because of that, and because of the growth of the program, what we're doing is seeing evidence of cost shifting. Right? And this is from, I think it's New England Journal of Medicine study. Oh, no, this is the GAO statement on it. This is the New England Journal of Medicine. Both private and public are finding that, in fact, there is cost shifting. So non-340B patients are paying more for their drugs because of the huge discounts that are coming through the 340B program. And we're also seeing consolidation of medical practices. When we looked at those entity sites, what you're seeing is if you were an independent cancer center, right, the drugs that you're using are very expensive. So that 340B discount is worth a lot. And so what you've seen is oncology practices are no longer independent. They're now part of big hospital systems. Higher costs are associated with hospital systems, plus quality of care. Patients who would prefer to be independent, they can't do it. And that leads us to why we need to reform. Some of the reforms we're talking about is, most importantly, transparency, restrictions on contract pharmacies, trying to get back to, you shouldn't have 150 contract pharmacies, not necessary. Boston General has a contract pharmacy in Florida. That's a bit excessive. We need to roll those back. We also need to make sure that the patients benefit. This is something I hit upon, but when you talk about a patient's coinsurance cost, that's typically not based on the 340B price. So in the example I gave earlier, it would be based on $1,000. So even though the cost to the hospital is based on $500, patients paying their coinsurance on 1,000. So patients aren't directly benefiting. That it isn't part of the program, but it should be. And that's something we're talking about reform. I think that's something that's very important. Again, bringing in the contract pharmacy program, and then restricting expansions to medically underserved areas. Right now, a very profitable strategy is pick up an oncology center in a very rich neighborhood where people have lots of good insurance. You're going to get a lot of money. But again, the purpose of the program is to serve medically underserved. It should be restricted to those areas. So, just thank you so much for the time.
Thank you, Wayne. That was extremely informative, trust me. And now we'll hear from Miranda Motter.
Figure out how to. He's going to do it. Thank you very much for the opportunity to spend a couple of minutes with you. As you said, I'm Miranda Motter. I am with AHIP here today, and just wanted to spend a couple of minutes talking about the 340B program, and with particular emphasis on the parties and the disputes that I know many of you that we've all read about in the press, but to really try to provide some additional granularity around that. I'm not going to try to duplicate any of the information that Wayne has shared, because I think some of the information that he has shared you will see here in my slides. But where I talk about it, there is an emphasis that I think is really important as we think about the program, as we think about the disputes and the problems, as Wayne's talked about, but then certainly to think about if there are solutions that should be considered. So as I said, I'm going to just spend a couple minutes talking about the purpose, and the participants, the essentially super high level about how it worked, and we saw Wayne's flow chart, and I will share a similar one as well, and then really spend most of my time providing again some granularity around the disputes and where they lie and why. As Wayne also articulated, the purpose of the program, it was created by Congress in 1992. And again, we hear over and over that the purpose was to stretch scarce federal resources to reach more eligible patients and to provide more comprehensive services to low-income patients and to uninsured patients. Here, I think it's really important, and while Wayne talked about it to some extent, I think it's really, really important to focus on who the participants of the program are. And there are four main categories of participants. The Health Resource and Services Administration, referred to as HRSA. The Office of Pharmacy within HRSA is actually the administrator of the program. And that's really important, particularly as we talk later on about the disputes. Drug manufacturers who are participating in the Medicaid drug rebate program are participants. And it's really important, again, to note that drug manufacturers must participate in the 340B program in order to have their drugs covered under the Medicaid program. So that is, again, another really important distinction, that there is essentially an exchange they receive, right? They provide their drugs at a discount in the 340B program, and as a result, their drugs then are available in the Medicaid program. We talked a little bit about covered entity and contracted pharmacies. Contracted pharmacies, essentially, the way I think about it is stand in the shoes of the covered entity. And as Wayne said, under HHS guidance and HRSA guidance, hospitals are utilizing contracted pharmacies in ways that are permitted under the ACA due to the expansion of the program. It's also important to, again, focus on the eligible patient. So the law, the regulations in HRSA is very clear about the types of patients that should be receiving the discounts and the rebates. And they're essentially those that receive care from a covered entity. So let's talk just a quick, again, minute about how the program works. As I said, drug manufacturers essentially provide a discount. Wayne talked about it being 50% or more, but I think generally what we hear is the average is anywhere between 20 and 50% on outpatient drugs that are purchased by covered entities. Again, the drug discount is given in exchange for coverage of their drugs in Medicaid. The covered entities and contracted pharmacies must comply with all the 340B program requirements, including making sure that the drugs are distributed and given to eligible patients. You'll hear sometimes referred to a prohibition about duplicate discount. And this is really in the Medicaid context where manufacturers are, their duplicate discounts, so discounts that result from 340B and discounts that result from the federal rebate program are impermissible under Medicaid. That's not the case necessarily in the commercial market, but you may hear references to duplicate discounts. And then lastly here, and you'll see throughout my presentation, there are a number of links because I do think it, again, is very important as you are considering this issue to really go to and look at the resources that are out there, whether it's the HRSA's FAQs, where it talks very specifically about covered entity requirements, contracted entity requirements, drug manufacturer requirements. And so I just wanted to make sure those links were there and available. This is a slide very similar to what you saw Wayne present. It is simple math, where you see the discounted drug, the discount being given by the drug manufacturer to the hospital or the covered entity, and then what the reimbursement for that drug is, and then certainly the difference or the delta of that goes back to the covered entity. One of the things that I think is really important, again, as we look at the disputes here, is that this is not a health plan issue. The disputes that I'll talk about here in a minute are disputes between drug manufacturers who are essentially in some instances resisting the 340B program requirements by providing those 340B discounts. That is one situation. And then the other instances where drug manufacturer may be imposing certain conditions or restrictions to make sure that they get the information they need or to ensure that that drug is going to an eligible patient. And then the other sort of group of disputes that you'll see here in a minute is really by the covered entities. So those who are seeking to protect those scarce resources, to protect those funds that they are receiving under the 340B program to use for a variety of purposes. This is a high-level review of where the disputes lie on the drug manufacturer side. Again, here, I think it's really important. I included here the materials around the 340B advocacy that you'll see Pharma has put out and put forward. And again, I think it's really important to see those things and their rationale and dispute as it relates to providing the rebate to covered entities. You'll see here that initially, I think the major dispute started when notices by a small number of drug manufacturers gave notice to HHS that they were going to limit and not provide the discount. Quickly thereafter, you had a number of other drug manufacturers follow suit, and I'm going to go ahead and move to the next slide. Again, this is high level, and my next slide is pretty dense, I'm going to warn you. But this really provides the backup or the additional detail of the bubbles on the prior side. So, just walking through this, as I said, other drug manufacturers quickly followed suit after a couple of drug manufacturers indicated that they were not going to provide the rebate. 17 drug manufacturers, I believe, to date have indicated that they are not providing that discount. And then, as I said, about 10 of those companies have indicated that they will impose certain restrictions to make sure that they get the information back that they need from a covered entity. In December of 2020, as I mentioned, HHS issued an advisory opinion that concluded that drug manufacturers are required to provide that discount under the program on covered outpatient drugs when a contract pharmacy is an agent for that covered entity. Additionally, in December of 2022, HHS issued a final rule as it related to their administrative dispute resolution process. Drug manufacturers quickly and along with pharma have filed suit that challenged the HRSA's advisory opinion as it related to contract pharmacies standing in the shoes of the covered entity or the ADR process, and some manufacturers are in disputes as it relates to both of those things. You'll see there between 2021 and 2022, HRSA sent letters to drug manufacturers. You can see the letters there on HRSA's website to those drug manufacturers that announced they would not provide the rebate, indicating that they needed to do that per HRSA guidance. And then in September of 2021, HRSA has referred a number of those cases to the Office of Inspector General within HHS. So again, a quick high-level overview of where the disputes lie and really the perspective of the drug manufacturers as it relates to the 340B program. Let me quickly move to the disputes on the covered entity side. Again, wanted to provide sort of the high-level overview of all of the different categories of disputes that we see on the covered entity side. Again, I wanted to show and provide to you information that's publicly available on America's Hospital Association website of what they believe the challenges are, which again are really focused on the drug manufacturers. And then an additional, some resources there by the 340B Health, which is essentially a member association of hospitals that are working on 340B advocacy and reform issues. So let's go to the details slide. Again, I apologize for how dense this is, but I did think it was important to provide either the links or further information about all of the disputes. So let's start with the Hospital Association and 340B providers. Quickly after those drug manufacturers announced that they were not going to provide that rebate, they sent letters to those drug companies asking them to reinstate those discounted products, the discounts on those products. Thereafter, those 340B providers filed suit to really ask and to enforce HHS's obligation as it relates to drug manufacturers and enforcing the program and the drug manufacturers' requirements. Related to 340B disputes, but different than the drug manufacturer issues, I did think it was also important to highlight that CMS, during all of this, also issued a rule that would have essentially cut Medicare payments for drugs that were acquired under the 340B program. And so as you can imagine, there were suits and litigation that followed as a result. And most recently, just a couple of weeks ago, the U.S. Supreme Court issued a decision in that case. So you may have seen some of the public press and coverage as it related to that decision. So again, in short, as you can see here, a variety of disputes that really at its core are about the discounts that manufacturers are required to provide, and on the other side, the covered entities and the contracted pharmacies and their role and the funding that they receive, the important resources that they receive under the 340B program. Again, I think it is, really important to note that this is not a health plan issue for all of the reasons that I just walked through. And, in closing, I would say it is really important to be cautious against and caution any type of legislation, policy proposals that would essentially leave the ultimate purchaser of health care, which is the employer, the individual patient, from being left holding the bag. And when I say that, I mean making sure that proposals don't relieve drug manufacturers from paying that rebate when they are required to pay that rebate under the federal program. And then also, likewise, making sure that any proposals don't relieve covered entities from having to comply with the program's requirements as well. And with that, I'm happy to take any questions.
Thank you. Oh, we have. Okay. Thank you, Miranda. That was very informative as well. We're going to go to Greg Doggett. If he's here, he has a few words he'd like to say.
Is this on? Oh, Greg Doggett with 340B Health, the organization that was mentioned earlier. Just wanted to thank NCOIL for its continued interest in 340B. A lot of interesting information shared. I would like to highlight that a lot of the issues raised today are primarily federal in nature. Going back to the Health Committee's discussions at the last two NCOIL meetings about 340B, one area that is ripe for state regulation, or I should say state legislation, is regulation of PBMs, specifically legislation that would address discriminatory payer practices such as low reimbursement. States have already shown a tremendous interest in this issue. We have now 24 states that have already enacted such laws. So I would encourage the organization to continue to consider the model legislation that was discussed at those last two meetings. Also, in light of some of the information shared today, I just wanted to briefly mention a couple of research points that I think demonstrate that 340B continues to target the proper hospitals that serve a lot of low-income patients or patients in rural areas. 340B hospitals make up only 40% of the hospitals in the U.S., but they provide 60% of all uncompensated and unreimbursed care. They also provide 75% of total hospital care to Medicaid beneficiaries. And then just one last point, critical access hospitals, hospitals where healthcare access is a major issue, consistently report the 340B as one of the lifelines that just simply allow them to stay open, especially at a time like COVID, and especially when so many hospitals are facing closure in rural areas. Thank you.
Thank you, Greg. And now we'll turn it over to Assemblywoman Pam Hunter for comments.
Great. Thank you, Chair. I just took a couple notes, and I'm sure others have questions. So one of the points that Miranda had repeated a couple of different times is that this is not a health plan issue. It's a drug manufacturer issue and covered entity, so it would have been nice to actually have pharma here to speak on this 340B issue. Also, we really wouldn't be needing to have this discussion if the drug prices weren't so expensive in the first place, which I feel like we don't have many conversations about that got us into this position in the first place. But my two kind of question points, which I don't know if we answered today or not, is identifying the need population and what that looks like relative to safety net hospitals and their need. Because if you are talking about a situation like where I live, where I have an FQHC and a safety net hospital, this hospital has hundreds of millions of dollars for their programs and services, and the savings that they're getting, yes, benefits programs and services, but the $1 million of savings that comes to the FQHC cannot be replaced by, there's not enough chicken dinners, there's not enough galas to supplant $1 million. And so I think that needs to be addressed, and I'd like to know how we're going to go about doing that, and also what is the federal government's plan to supplant this removed money. The state of New York is talking about, we want our savings back. All of a sudden it seems like a money grab from the state, trying to take this savings money back. We want the discounts, but who is going to give an FQHC that money that they were using directly to give for programs and services that they're not going to have otherwise? So I don't know if you all have the answers to these questions. I think that this definitely warrants more discussion than, unfortunately, a limited amount of time that it allows. But this is a very serious problem that I think we need to have some more people at the table to address. Thank you.
Thank you, Assemblywoman. Now, we only have time for 3 more questions, so Senator Hackett.
Okay. Thank you. And I agree a lot with what Chairwoman Hunter said. The question I have, and it's also what's being done in Washington. I've been involved, and Miranda will tell you, a long time on 340B, and if you look at 340B, initially you had the veterans, you had the FQHCs, and you had the high-dish hospitals. And then in the last 10 years, President Obama allowed a lot more hospitals to get involved. So the biggest issue is not the FQHCs and the veterans. I mean, I think if you talk to people in Washington, it would destroy them. It would really be bad. And I've yelled at Miranda when in Ohio we kind of protected them, but we had some companies, drug companies, that basically kind of said they weren't going to pay the discount. And you got to realize a lot of our FQHCs are working in deserts as it is, and if you cut out one of the, like Walgreens or CVS, you may be cutting out. They have to have them if they don't have an in-place pharmacy. So the question I have is, when they set the law 10 years ago, whenever they did it, that the additional dollars had to be used. They were a nonprofit. They had to use the monies under specific rules that the feds dictated. Is that been changed? I mean, is that being to the point where that's been strengthened? Is there any negotiations go on at the federal level? I agree with what that gentleman said. This is a federal issue. It's not a state issue. It's a federal issue. And so is there anything been going on in the federal issue? Because we cannot let, pharma and them just dictate to us to cut this out. I understand the issue with the one set of hospitals. I'm not in the middle of that. They can fight that how they want. But is there anything being done at the federal level to get this thing resolved, that we don't keep fighting this over and over and over? I don't know if you want to answer, if that gentleman that came up, maybe he wants to answer it. What do you guys think?
You want to take it first? So I'll start, and Wayne and Gary might have some comments too. I mean, from what I understand, there have been attempts and work, whether it's at the congressional level or through HHS, to try to adjust and reform the program. But it remains as it is today by the ACA and by additional laws and regulations post that. So I am not, certainly it has not been changed. But I would just continue to reiterate what Wayne said is, this is it's a federal program. These challenges lie at the federal level because of the way it is currently situated.
But if the law hadn't changed, we wouldn't have this problem. Everybody remember that. I mean, what was done in the last 10 years? You wouldn't, the Congress would have left it alone. We would have helped the ones we were helping. And so adding that layer of hospitals into the system is what has created this problem from day one. And I'm not making a value judgment whether they should be in or not. I don't want to have them yelling at me, but it's just an issue. That is the issue, is we had additional hospitals that qualified for the dollars. If they hadn't have done that, we wouldn't have this problem.
And some of that wasn't intentional, right? When we expanded the ACA, when we created the ACA, we expanded Medicaid. When you expanded the Medicaid population, you brought hospitals that weren't part of the program into the program. So there's a lot of unintended consequences when you're looking at the issue of 340B. So nobody intended for some of these things to happen. They just have happened. But direct answer to your question, there's no legislation moving right now at the federal level that would address any of these issues.
I was going to address one point that you mentioned about the contract pharmacy restrictions. In the waning days of the Trump administration, they put in an opinion to say what manufacturers were doing with limiting 340B pricing for contract pharmacy was illegal, violated the statute. The Biden administration has maintained that position. Numerous pharmaceutical manufacturers are suing the administration, and there's multiple cases tied up in courts. One thing I would mention was that the ACA did expand the number of hospitals that were in 340B, but these were mostly just small rural hospitals, cancer hospitals, and children's hospitals. DSH hospitals already qualified for 340B and have since the inception.
No, I'm going to argue with you on that, because if you look at Ohio, the rural hospitals are all owned by the big city hospitals. So you may say that, but that is not true in Ohio. That is not true in Ohio.
Yeah, I hear what you're saying. I'm just saying the rural hospitals and the bulk of the, like if you look at the total count of hospitals, are small critical access hospitals. I'm not disagreeing with you that some of them are part of health systems and some of them are a bit larger. Thank you.
Okay, everyone. Unfortunately, we will not be able to get to our last two questions. Thank you, Senator. We have to move on, but this is why we need to look at this closely, put our due diligence in. Thank you so very much to our two panelists. Our next topic is focused on international insurance issues of legislative and regulatory concern. With us today are Dean Cameron, Idaho Insurance Director of NAIC President, and Gary Anderson, Massachusetts Insurance Commissioner and Chair of the NAIC International Insurance Relations Committee. So please go ahead, Director Cameron.
Thank you, Madam Chair. It's a pleasure to be here with you, and we're grateful for the opportunity to provide you with an NAIC update to key international issues. Some of you may be considering, why is it important for the NAIC and for you to be aware of these issues and be involved as heavily as we are? We all guard our consumers and want to protect our consumers so that they aren't hurt. And with that comes the responsibility of protecting carriers who are both selling here in the United States as well as selling in other entities. We also want to be able to help those countries who have less of a robust regulatory system or are trying to figure out their regulatory system or what's appropriate, and we can talk about some of that. And then thirdly, we know that it's important for us to build relationships as we battle some of the issues that come forward. Now I'm going to turn, if it's all right with you, Madam Chairman, I'm going to turn to our NAIC G Committee Chair, Gary Anderson, who's also from Idaho. I think it's kind of interesting that you've got two of us from Idaho, but he lives in Massachusetts currently until I get him converted back. So go ahead, Gary.
Thank you, President Cameron, and thank you, Madam Chair, to you and the committee for having us here today. It's really a pleasure for me. I started my career in the insurance world for a regional carrier in the northwestern United States, and then I had the opportunity, I think probably will always be my favorite job, was a counsel in the Massachusetts legislature working on insurance and banking issues at the intersection of law and politics and policy, and now have the opportunity to serve as the insurance commissioner. So I feel very fortunate to have seen the market from a few different perspectives. So as President Cameron noted, this has been a critical issue for a number of years, and maybe I'll just set the stage a little bit, and I can do it quickly. No, we have a limited amount of time. But just to go back a little bit to set some context, if you go back to 2013, so this is not long after the crisis, and the Financial Stability Board charged the IIS, that's the International Association of Insurance Supervisors, with creating global capital standards. And as part of that, if you recall, at that time, there were 9 firms that were designated as potentially systemically important insurers. Those are G-size. Those 9, and 3 of which were from the United States. So we have long held here in the United States that it's not just the size of these entities that may or may not pose a risk, but what kind of activities are they engaged in? And so when you're developing capital standards, I think it's also a challenge to think about creating one capital standard for the globe when all of our jurisdictions, particularly here in the United States, is so different from another. For example, another country in Europe. So it's been the belief of Team USA, we'll call it, that the capital standards have to account for the differing legal frameworks of the jurisdictions across the globe. I think it's fair to say, going back, so now that was 2013 with the charge. Since then, a lot of work has been done. In 2019, we were faced with a little bit of a challenge at that time. I think there was some momentum on the side of some of our colleagues from overseas with regard to developing this single global capital standard. And we had said for years that this would not be fit for purpose here in the United States. The United States had been developing our own group capital standard, which is known as the GCC, the group capital calculation. And that leverages the structure of the United States, which is it takes the legal entities across within a company and it aggregates that capital to develop a calculation at the group level. We had pushed for that. I think in 2019 we were challenged because there was no mechanism in place for us to be recognized for the work that we were doing. And I would say for Team USA, I think we helped to reshape the dynamics, the power dynamics, if you will, in 2019 in our favor. And what we did was through the IS, there was being developed the International Capital Standard, the Insurance Capital Standard, the ICS. We needed a framework to compare what we were developing here in the United States, the group capital calculation, which is known as an aggregated method because it aggregates the capital. It's also, we've argued for years, jurisdictionally agnostic. So if you're a jurisdiction like President Cameron said that is a developing nation and you're looking for a capital calculation, this will work for you too. So we were fortunate, and I think through a lot of hard work, we're able to develop a framework to compare these two standards. That's known as the comparability assessment. So for the past several years, since 2019, we were able to put that in place. We've then been developing, first we came out with areas that we needed to focus on for this comparability assessment between those two standards. We then took those areas of focus and we built them into what are known as high-level principles. And throughout this process, we are engaging with stakeholders, and we go through consultations. We get input from the industry, other stakeholders, and we took those high-level principles, and now we're at a point where we're developing the last stage of that is what's known as criteria, a little more defined. That is now out for consultation here across the globe, so our carriers will be commenting on this last set of criteria that help build the framework to compare these two standards. I think, leading up to, we had an international forum in D.C. a couple of months ago. There were a few things that we needed from our international colleagues to move forward in this process. We were able to achieve those things. Those are, making sure that stakeholder input is not only heard, but is taken on, that it is used in the development of this criteria. And we were able to get that. We were also able to, had some concerns at this assessment, this comparison will be made at the end of 2024. We had some concerns about the makeup of the team of assessors. We got that fixed. So I think we're on a really good path at the moment. I think that's a lot of effort that's been done over a number of years by Team USA. That includes, our NAIC colleagues, that is the Federal Reserve, that is Treasury, that work with us as partners in our effort. So at this point, we're in a good place, I think, through not just that, but we've now developed over the years kind of a common framework, if you will, to discuss these issues with supervisors across the globe. We hold supervisory colleges. So let's say, for example, Liberty Mutual, which I am the group-wide supervisor for in Massachusetts, will hold a supervisory college. So regulators from across the globe will come in and we'll discuss issues relevant to Liberty Mutual. So we have done a lot of work to develop these common framework, common language. We assess risks across, again, the activities, that is within insurers, but also within the market. So I'll turn it back to President Cameron. I think he had a few things to say on bilateral engagements, but I think we're in a very good place as far as the efforts we've made over the last several years.
Thank you, Gary. And thank you, Madam Chairman, again. Just to touch on quickly, we've also been, besides the battle that's sort of been going on and with the aggregation method and the ICS, we've also been engaging in a number of bilateral communications with other countries. Singapore, Taiwan, and Hong Kong, and Japan we met with here recently. We also met representatives from Australia, Canada, South America, South Africa, Argentina, and Brazil. And we signed a memorandum of understanding with CIMA, which is the organization in Africa that most represents the majority of countries there. With that, Madam Chair, I know we're pressed for time, so I'm happy to turn it back to you, and Gary's happy to answer any questions that anybody has.
First of all, I'd like to thank you both for your presentation. As you were talking, I'm just up here saying, this is it. This is where I want to be. This is where I want to land. And it's really great. Do we have any questions? Yes, Representative Meskers.
Thank you. So I want to thank you for the work you're doing for the oversight. Obviously, the regulatory framework on an international basis and a local basis for our insurance companies is super important. In relation to your work in the NAIC, you know, I've been reviewing, and we just finished a conversation on 340B, and now we're moving on. So when we look at the regulatory framework, there's a second part of the equation, which is looking at the insurance industry and its future health and sanity, which is related to the cost structure and the payment structure of the insurance company. So we're having the conversation about 340B, policy benefit managers, et cetera. When I go into U.S. government research, there's a Ways and Means Committee report on 2019 mentioning that the U.S. pays about 4 times what the OECD countries pay for its drug prices for the pharmaceuticals. And I think for the sanity of our NAIC and our regulatory framework, we have to address that elephant in the room, which is what are we going to do about pharmaceutical prices, the potential at some point for a cap in the United States so we're not paying 4 times what the OECD are doing, and what's the regulatory premium we want to see in the United States to keep research and development in the United States, and at the same time give our constituents affordable health care. I can't explain to people why drugs are 4 times more expensive than Canada. And if I tell people to go up to Canada, the pharmaceuticals say they can't ship to Canada because it ends up in the U.S., so they're going to limit supplies. So we're going to have to figure out a pricing mechanism where we guarantee a profitability, keep an industry that saves lives and does a great job for the United States, but I don't know where we stand on that, and how important is that in terms of your regulatory oversight?
Yeah, Representative Meskers, not necessarily what I was prepared to talk about, but I can say I share, I think, as regulators across the states, we share the concern about pricing. I mean, we, in Massachusetts, we go through a healthcare rate review every single quarter, which is a challenge. And you see that the drug prices take up, a little bit more each time of the chunk of overall costs relative to a premium that's paid by each of our policyholders, our consumers. There have been some efforts, I can speak only, for Massachusetts, to address that through legislation that Governor Baker had filed. And, whether the legislature has kind of the desire to take that up, and the time we finish our legislative session here at the end of July for this 2-year session. But it's certainly on top of mind. And to your point about the value, a good friend of mine, the former superintendent in Maine, used to say, if you're not at the table, you're on the table, as the meal, right? And I think that goes for these discussions, but also at the international level. If we're not engaged there, then things will happen to us, which happen to our carriers, which happen to our policyholders. So it's really important that we're engaged to push our policy. And particularly on this one, I wish I had a silver bullet on this one. It's been a challenge since I've been the commissioner and before. So thank you.
Thank you.
And
We
then- sorry,
must
just-
move.
could
Oh,
I-
go ahead.
Yeah.
Representative.
Just if I could suggest to the NAIC commissioners that I think the message to Washington has to be the credible management of our pharmaceutical pricing versus the rest. I mean, we want the industry and the research here, but we all need to think about where we're going with the price structure we're seeing. I mean, in Connecticut, we're talking, I think, on the order of 20% price increase this year, and that's not sustainable over time.
Oops, thank you very much. Okay, we must move on. And now our final presentation. We'll hear a presentation on developments surrounding new treatments for Alzheimer's disease. Here with us today is Carter Harrison, Director of the State Regulatory and Legislative Affairs Alzheimer's Association. Please go ahead, Carter.
Thank you, Madam Chair. Just wait for my presentation to come up here. Today, I'd like to speak briefly about the new advancements that are occurring around Alzheimer's treatments and the potential impact that these treatments may have on state policy work moving forward. I'm going to start with a bit of a review of the drug that has sort of kicked off this process, and I'm sure you all have seen this in the news around Aduhelm or aducanumab, which is a MAB, which is a class of drugs that seeks to remove amyloid buildup in the brain, which is one of the markers for Alzheimer's type dementia. This drug has been approved to treat the early stages of dementia, so that's mild cognitive impairment or early Alzheimer's disease. And this is currently the only FDA-approved treatment that treats the pathology of Alzheimer's disease, and it was approved under the accelerated pathway. Again, something that was noted quite a bit in the news. Also, things that were not noted but are important for policy considerations in the future is that this drug is administered by IV. It is not an oral drug. And there are some very important parts of the label that deal with safety related to ARIA, which is very dangerous if it's not monitored, and will have some future state policy impacts additionally. So I'd like to start with where the Medicare CMS determination for the national coverage decision. And I'm going to essentially break this down into a couple of different sentences, although there's quite a bit more detail up here. But basically, in order to have this covered under Medicare, you will have to be in some type of clinical trial. So there are various options for those clinical trials, which you will see up here, whether they be NIH studies or CMS-approved studies. But in all cases, you will have to be a part of a study in order for Medicare to cover the cost of this drug. As you can see on the last point on the slide, outside of this criteria, the drug is considered not covered by Medicare. Now, this has a number of implications. Obviously, the first one that I'd like to start with is on the Medicaid front. So for those of you that are not as familiar with the Medicaid program, but if a manufacturer participates in the Medicaid drug rebate program, the drug has to be covered, and this was tangentially touched upon in some of the earlier presentation. And of course, the manufacturer for Aduhelm does participate, so therefore the drug has to be covered under Medicaid. Of course, states can and have restricted the use of this drug through utilization management techniques in order to make sure that the population is targeted to what exists in the label for the drug. And additionally, one of the issues that has come up as a part of this decision is that the drug, when covered by Medicare, is considered a Part B drug, and when not covered by Medicare is considered a Part D drug. And the reason that that's important is because Medicaid cannot pay for Part D drugs for full dual eligibles. So you have a circumstance where dual eligibles cannot receive this drug, but other recipients in the Medicaid program, at least theoretically, could if they meet the prior authorization criteria. So, as you can imagine, this was pretty devastating for any person that is currently living with Alzheimer's disease. But I did want to sort of highlight some of the responses to CMS's decision where there may be at least a bit of hope for the future. So first of all, while this did apply to the entire class of drugs, of which there are several in the research pipeline currently, it does not mean that Medicare and CMS will not evaluate each one individually, and if the data is convincing or more convincing, then they may change this current NCD. In addition, they did talk about how this was promising but not quite meeting the statutory requirement for it to be covered. Again, a little bit of I'm sort of taking the glass half full versus the glass half empty approach to that piece as well. And also, there are going to be future MABs that come forth, and I think there's a lot of things that we, as the policymakers in the states, I don't mean we as in myself being a part of that, but we do participate in that process. But you guys as policymakers in the state will have a lot of opportunity to help impact this. And I'd like to use this chart to sort of demonstrate how I think that will happen. Now, this chart is, again, demonstration purposes only, but it shows how a person normally ages and gets diagnosed. And at this point, the star here represents age 65, diagnosis at that age. And then you can see sort of a rapid cognitive decline. Also, you'll note in the chart, again, for demonstration purposes, that the individual has been declining prior to the diagnosis that they received and perhaps receiving care. This chart shows something that I hope we get to in the near future, which is a place where an individual has only a mild bit of cognitive decline and is there then diagnosed at an earlier age. And here, for this chart's demonstration purposes, we are looking at age 45. And then they begin to receive a treatment that slows their cognitive decline. Now, when you put these two charts next to one another, you may not think there's a lot of difference between the rate of cognitive decline. However, what I'd like to point out is that there are a lot of cost savings to the healthcare system by avoiding as much healthcare needs, especially on the long-term care side, especially for Medicaid spending, here where you reduce the amount of time or you lengthen the runway for that individual's cognitive decline. Not to mention the fact that the person with the disease will have more time to spend with their families, more time to do planning, more time to be a part of normal society. So in the end, there's a number of questions that I think states will be addressing as these treatments move forward and are starting to service the dementia population. One of those areas will deal with genetic testing and diagnosis protections. If you have individuals that are going to receive a diagnosis when they are younger, perhaps when they are still working, it's going to be very important that that individual that might be undergoing treatment receive the protections that are necessary in order to continue to work or be participatory in society. Especially if there is a genetic test. There are several forms of dementia that genetic testing does indicate that the individual may or is more likely to develop dementia, and those types of protections are going to be needed. Additionally, testing is very important, as also mentioned in the NCD, but right now these drugs, the labels want you to confirm that there are amyloid buildups in the brain, and that is currently done by either spinal fluid or PET scans. Both of these, the PET scans particularly, are very expensive, and they may have a certificate of public need issues related to them. There is a possibility that in the near future there will be testing that is not as expensive or does not require these types of machines, which actually makes this even more complicated because providers may not be willing to invest in this equipment that would be necessary to do the treatment and to monitor it safely. So earlier I referenced the scans for ARIA. The label for ADUHELM currently requires constant monitoring through MRIs. It is certainly possible that future drugs will have similar requirements, so there will be additional costs and additional needs there. The next item deals with drug delivery. You heard me state earlier that the ADUHELM was an IV drug and would be administered in a doctor's office or perhaps some other type of clinical setting. Most of the drugs that are currently in the pipeline also are administered within the clinical setting, and so it's going to be important to make sure that those settings are available and able to handle it. Lastly, there's a couple of coverage implications. The reason that I went through the chart was to point out that most policymakers think about Alzheimer's as a Medicare problem and possibly a Medicaid problem. But as these treatments come to market, that the line will start earlier before an individual is likely eligible for Medicare or Medicaid. And so that will push the treatment options closer to the private insurance sector, and will start to have impacts on private insurance as these treatments continue to be developed. And then, of course, lastly, I have state employee health plans. I think many of you can think about other types of treatments that have come out and the policies that have gone into those, whether they be cancer, and the impacts they've had on the state employee health insurance plans. So with that, I will pause and ask if there are any questions, Madam Chair. Thank you.
Thank you, Carter. We do have a question from Representative Ferguson.
Thank you, Madam Chair. How many clinical trials are running right now?
Madam Chair, I would say to the young lady that I don't have an exact number, but I'd be happy to check with our colleagues and get you the number.
I guess I was just curious, is there a trial in most states or no?
Not necessarily, no, ma'am.
Okay, thank you.
Any other questions?
Ma'am, which state are you? Arkansas? So we have identified an interesting problem in Arkansas, and that is a lack of PET machines. So they don't have the PET scanners available to the population there, and so they would have to go outside of state in order to participate in those types of trials. So that is an issue for your state.
Okay, thank you. We'd like to thank Carter for his presentation, as well as everyone who presented to us today. At this point, we're going to I'll open it up for any other business that needs to come before this committee. Okay, hearing none. I'd like to inform everyone that the Griffith Luncheon is next, and it's right next door to this room in the Harborside room. It's open to legislators and regulators. Hope to see everyone there. So seeing no more business before this committee, I'd like to hear a motion for adjournment. Okay, it's been properly moved and second. All in favor say aye. Those opposed can stay in the room. Bye now.
Well done.